Hello, and welcome to Dyscrasias Clinical Education's Oncology podcast. I'm your host, Kendall Schick. On tonight's episode, we are joined by Dr. Muhamed Baljevic from Vanderbilt-Ingram Cancer Center in Nashville, Tennessee, and Dr. Johnathan Ticku from the Mayo Clinic in La Crosse, Wisconsin. Today, they will be discussing various strategies to optimize the use of bispecific antibodies for the treatment of relapsed and refractory multiple myeloma. This episode is part of a larger educational program titled Addressing Challenges and Implementing Care Strategies to Optimize BCMA Bispecific Antibody Therapy and Relapsed Refractory Multiple Myeloma. For more information about our guests, along with a link to the educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say about bispecifics and myeloma.
Good afternoon. My name is Muhamed Baljevic, and I'm a director of myeloma program at Vanderbilt. And I'm joined by my colleague, Dr. Johnathan Ticku from Mayo. And we are talking today about bispecific antibodies and experience, particularly in the outpatient setting and among community centers, sandwiched with experiences from academic environment. And we want to thank Dyscrasias Clinical for organizing this and helping us connect and learn from each other.
As a community oncologist and getting started with outpatient step-up dosing for bispecific antibodies, we have now a variety of drugs to think about. What are the things that we should take into consideration when selecting these patients? And is there a benefit of choosing one agent versus the other for this?
So within the BCMA space, certainly in my clinic and what I've observed among my colleagues at my institution, we don't necessarily have a defined preference when it comes to efficacy or safety profiles. Tocilizumab came to market in October 22, and elranatamab came on market in August 23, so nearly a full year later. So it's reasonable to assume that most providers have had a little bit longer experience with tech. However, we have both tech and elranatamab on formulary and approved and in use at our institution. We use them both. One of the things that was part of the reasoning why we included elranatamab on our formulary was also the fact that per label suggestions / recommendations for inpatient hospitalization periods during the step-up dosing is the fact that elranatamab had a 24-hour rather than 48-hour recommended monitoring after second step-up dose, and then the third dose, which is a first full weekly dose, could be done fully outpatient. So patients that are considered desirable for preferential inpatient step-up, that would be a situation where you could save some hospitalization days and be more cost conscious in terms of healthcare utilizations. Certainly in terms of efficacy, I can briefly cover the fact that after median follow-up of just after 30 months for Majestic-1 study, which was registrational for tocilizumab, the median overall survival was just over 22 months. It was fantastic. And it was clear that deeper responders were doing better. So the overall cohort in terms of PFS was about 11.4 months. But then, importantly, those who were in CR response or better, median PFS wasn't even reached. And the VGPR or better responders had a 26.7 months, so more than double in terms of benefits. So that's really notable. There was a nice real world data also follow up recently with a huge number of patients, over 500 patients that had a somewhat shorter follow up still. But what I liked in that study is that most patients that were included, 89% of them would not have met the defined eligibility criteria for Majestic-1. So I really enjoy reviewing the real world data and experiences because these were hundreds of patients that have never been part of the trial data. And, 6-month overall survival was 73%, 6-month PFS was 53%, and median duration of response was 11 months with CRS and ICANS and infection occurrences not looking dramatically different at all compared to what we saw. And then magnetism, of course, was registrational for elranatamab, and day after latest data cut, which was in March of 24, 28.4 months of follow-up, had a median PFS of 17.2 months, median overall survival 24.6 months, and also some nice real-world data, 130 patients or so with elranatamab as well. Though this one really had a short median follow-up, still of 7.5 months only, but PFS in an OS we're tracking. So I would want to see this cohort for a longer follow-up and then see how it plays out. Interestingly, there LDH was found to be a significant predictor of shorter survival and time to disease progression, and also hemoglobin levels. Patients with higher hemoglobin levels were more likely to achieve deep response and longer progression-free survival. Interestingly, also, and this is something that our patients ask us also, patients with prior exposure to BCMA-targeted therapy had lesser chance to achieving CR or better. So this is always something that we're thinking about. Johnathan, may I ask you?
Yeah.
I would really appreciate and love to hear
Yeah.
from you how your community-based experience has been with bispecific antibodies, particularly outpatient step-up. How often do you and your team fully step up bispecific in the outpatient setting, and how often
Yeah.
do you do the patients with continuous dosing after they've been stepped up? What's sort of the breakdown between inpatient and outpatient? How do you choose between that? That would be really
Yeah.
helpful, I think.
Yeah, so we actually kind of have the criteria of patients have to have a caregiver, as you know, and patients have to live within like 30 minutes of the emergency department. So we have a little bit more strict criteria on that because we're surrounding a larger medical center within an hour away. A lot of the times, if the patients are not able to be considered for, outpatient step-up dosing, they'll get that inpatient step-up dosing in the referral center. We always have to consider our own staffing as well, how busy in the inpatient side, how thin we are as far as staffing in the outpatient clinics, and those really kind of play a part. When we were designing our system, we wanted to know which hospital had longer wait times, like you're noting previously. With a CRS, you can't have patients boarding in the ED for like 8 hours waiting if they report a fever, et cetera, from home after a step-up dosing. So we have a lot of these criteria that we follow and plan accordingly. So it's usually the lower disease burden patients that are obviously relatively stable, fewer comorbidities, and then we'll consider those patients. For the most part, our plan is the way we set out is prophylactic tocilizumab, because if we're not a high volume place, we need to have those kind of safety measures are really appealing to us and our colleagues in our sister hospitals, community hospitals within our health system. So that's the way we've approached it. And we also have this unique feature with our system with remote patient monitoring, where we have this remote patient monitoring system where patients are taking their temperature, blood pressure, et cetera, once every 6 hours. And then that's uploaded into a system with a remote patient nursing that's staffed like 24/7. The protocol that we have for those nurses during the day, they alert our clinic, and then in the evening they'll alert the on-call provider, and then the on-call provider will then direct the care from there. So it's a little bit more of an intricate system, but it doesn't have to be that way in a lot of practices. I know a lot of practices around the country are doing it a little bit differently, where patients are just taught to take their temperature and blood pressure per usual and then report it as needed. So I think there's a lot of differentiation there, and it's not necessary to have such a remote patient monitoring system, but it does take a little bit of the burden off of the physicians. I think that's one of the big things. So coming at it from the perspective of being, I trained quite some time ago where we'd never had these technologies. We never had bispecifics. We never had CAR T cell. I'd never seen a toxicity like this. So getting people like myself and others comfortable. For instance, we have some doctors that pretty much see only breast cancer. So you have to educate them, take a lot of the burden off of busy outpatient clinical practice by using remote patient monitoring. These outpatient step-up dosing models will be more acceptable. So that's where we came from with ours.
And do you mind if I ask? I find that very interesting. You guys have done tremendous work at Mayo, really, in this space. We've also done several things that will be out. But what I want to ask you directly is about utilization of wearables. Do you still use wearables for bispecifics? and in what proportion of patients, because I can tell you, like you guys, we have for years given CAR T fully outpatient
Uh-huh.
with aid of wearables.
Yeah.
That's really facilitated things quite significantly. And then, after the arrival of bispecifics, we actually started using wearables also for monitoring and mitigation of CRS risk, etc. But frankly, we noticed very quickly that it wasn't really making a huge difference for us. So much so that we have actually stopped using
Hmm.
wearables completely in bispecific antibody patients.
Interesting.
The rates of CRS, and particularly high-grade CRS, is not really something we commonly observe. Occasionally we will, and we are not finding that this is something that we need to bring back. What are
Hmm.
your thoughts there?
Yeah, where our remote patient monitoring system is not using a wearable, it's basically like a connected device that will transmit the blood pressure and temperature directly to the the remote patient monitoring nurses. It's uploading the information to their dashboard, so it's not like that. What you're talking about is a wearable device that's kind of consistently taking temperature. We're not using a wearable device in our setup. The remote patient monitoring is just like an iPad mini that has its own data connection. Since we're in a more of a rural communities with the community oncology practices, so it has its own GSM data connection. They only take their temperature once every 6 hours and blood pressure once every 6 hours.
For how
Yeah.
long?
Oh, for about the first 10 days, depending on which bispecific antibody, but in this case, it's about 10 days.
So we have actually various wearables and wearable technologies that are, well, some of them are continuously in skin contacts for like temperature,
Hmm.
heart rate, respirations,
Hmm.
and then you can put on a separate piece of equipment for blood pressure, etc. But what I was mentioning earlier is we learned very early that we don't, not just that we don't need a continuous, but we don't necessarily even need a intermittent
Hmm.
collection of vitals at all. I mean, patients are always, have thermometer provided with one and are always instructed to take, temperatures should they feel like they might be developing
Hmm.
a temperature or if
Yeah.
unwell, etc. And in our hands, that level of, I guess, comparatively a little bit more de-escalated vital monitoring has
Yeah.
really been quite feasible, which to us is a welcome observation because we're in the process of trying to expand that approach to some of our community site clinics.
We have looked at a wearable device. It kind of sticks on the body and it can, I think it runs for like 90 days or so. Like you, I didn't feel like that was going to provide a lot of additional benefit to what the patients were already doing. Unless there's something that research wise they find that's beneficial, that, you know, but with the prophylactic tocilizumab, I think the CRS rates tend to be much lower. But we
Absolutely.
still have to be alerted. I think from what I understand, it reduced the grade 1 CRS, but the grade 2 CRS didn't really budge much. So we always will have to be alert to that still.
I think what might be helpful to really point out is, from last year, April or so,
Hmm.
NCCN guidelines really made a concerted effort to address this question and, in fact,
Hmm.
included a recommendation for consideration of prophylactic tocilizumab for CRS mitigation in all myeloma bispecific antibodies at this
Hmm.
point. We have four of them listed with the joining of linvoseltamab that was approved in July just last year. But yeah, I think you're alluding to also some of the other data points. I particularly like data from Miami. It was presented as a oral and then published recently in Blood Advances that looked at actually all bispecifics. They actually looked at linvoseltamab before it was officially approved. So the number of cases there was considerably smaller, but 40 teclistamabs, 23 talquetamabs, 40 elranatamabs were collected in that data cohort. And what they saw is really significant gutting of the CRS all the way down, an average of about 10% or so. And vast majority of that was actually low grade CRS, grade 1, with only a little bit of higher grade CRS. And ICANS were also actually, for talquetamab, certainly they were touch actually higher, but they were comparable for teclistamab and were not really observed on elranatamab at all, or linvoseltamab. So really encouraging data. And of course, we know from OPTEC, depending on which data cut you look, about 10% as well. And most of it is low grade. So I'm very enthusiastic about tocilizumab prophylaxis, and especially for sites that are just starting their experience, I tend to recommend that they lean into it and always try to ask for approval from the payers. And if they get it,
Hmm.
I see frankly no reason why they shouldn't use it, because it would certainly sort of level that risk. And even if the CRS was to happen, the likelihood is that it would be lower grade that can be managed way easier than needing active measures. And to that point, grade 1 CRS is something that we at Vanderbilt have stopped admitting. I mean, I don't
Hmm.
know how you do it at Mayo, but we no longer admit any grade 1 CRS. We manage it with pocket decks, which tends to
Hmm.
either completely interrupt any further CRS, or maybe CRS that would have been destined to be higher grade could end up being recurrent grade 1, in which case we do admit recurrent fevers and such. But this
Hmm.
has also ended up resulting in a lot of saved hospital days in our clinic.
I think we're using the same approaches. It's really oftentimes also provider discretion, but typically we would like to not admit all patients with grade 1 CRS for sure. I mean, that's a misutilization of resources. We kind of try and call it. The other question I got a question recently from our clinical pharmacist about the IVIG utilization.
Mhm.
So now, are you guys just right away giving IVIG for monitoring the IgG levels, and if 400 or less, like giving IVIG or waiting on that? And are
Yeah,
there? Yeah, go
that's
ahead.
a good question, honestly, because there's been, I mean, right over the last, almost 4 years, right? I mean,
Mhm.
Teclis came to market in October 22, so we're 3.5 years out already from the very first bispecific experience. I've sort of kept track, and recommendations have shifted earlier where they were, driven by the cutoff to the current. If you pull up, either MWG recs or NCCN recommendations, where really advisory is very loose and tends to focus around preference of the provider. So if somebody felt more comfortable to just those people, especially early on, regardless of what the level of IgG is, they could do that, and in all likelihood be supported by guideline recommendations with the payers. I would say, we're liberal with IVIG use also
Mhm.
because we have just freshly published our Vanderbilt experience with flat dose IVIG compared to
Mhm.
weight-based dosing. So I believe this is a unique piece of data in the
Okay.
world, and I don't know that anyone has ever published on this or even that they're using it. So we've, over many, many years, used IVIG with T-cell redirecting therapies, including CAR T and bispecifics in heme malignancies across the board. We've used the flat dosing 10 grams to start with, and then if that's basically achieving the need and patients are not having infections and IgG levels are, adequate, then we just continue, and that essentially can cut the utilization of IVIG like significantly. I mean,
Mhm.
100 kilogram patient, it would be a quarter dosing compared to
Mhm.
what we would normally give per weight based. And then the people who are not keeping the IgG levels replenished, then you can go about up to 20 grams. And in our hands, we recently published BCMA and GPRC5D bispecific experience in myeloma with, albeit limited number of patients. We'll have a follow-up with a larger group of patients. We didn't really notice comparatively to registrational study data that there was any meaningful difference in terms of, severe or mild infections, et cetera, between either of these groups. And we're in fact going to look at this within the consortium to see if there's any meaningful differences between, a couple of centers these days that are using it,
Mhm.
that have accepted to use it with the flat dosing like we do it, versus everybody else really that's using it weight based. So I think that's been helpful to us because it saves on the utilization of precious
Mhm.
resources, which I imagine will become sort of an issue in terms of access, no?
Yeah. Yeah. I often wondered that myself. I feel like we're giving a lot of patients like IVIG continuously all the time. I feel like, you wonder if it's going to be we're going to have to worry about running out of something, So,
Right. I mean, I remember times when IVIG was in shortage and only
yeah.
available for Guillain-Barré patients. And I mean, I certainly don't want to claim that this is ready for prime time. We just published
Hmm.
a single institution experience, but
Hmm.
in our hands, and we'll soon be publishing our CAR-T experience, but this has been very feasible and safe. So
Hmm.
that's a slight adjustment to what we do compared to what the guidelines are recommending. But we tend to be liberal at the beginning, and then later on, certainly in my clinic for patients who are already achieved response, and I have de-escalated the dosing frequency of bispecifics, particularly BCMAs, right? Because they're a little
Hmm.
bit more associated with infection signals. I tend to then follow more the IgG levels and
Hmm.
dose them only when they're less than 400. The
Hmm.
one thing that, to be honest, I still don't know about, and in due course we'll be learning more, right, is what the practice might evolve like for some of these combination bispecific approaches, right? Data was already published at ASH, and there's going to be follow-up data published this year because phase one is already done. And then, there's a series of bispecific plus CELMoD combinations, right, that are really appealing and powerful. I'm curious myself how that's going to look, and if we might need to consider higher cutoffs. I mean, who knows?
Hmm.
Like
Yeah.
500,
Yeah.
or more.
Interesting. So going back to just that IVIG question, that's always something that's changing. So you're starting IVIG right away, and then irrespective of IgG level, you don't direct it initially at an IgG level, or you don't
Initially,
wait.
correct. Initially, no, particularly in folks that are elderly, already had history of infections.
Hmm.
We just like to sort of treat them during the first, second cycle,
Okay.
load them up. And
Hmm.
particularly also because we're not doing weight-based, right? So we're doing 10
Hmm.
grams flat.
Right.
So they get some of this. And then I, I'm curious what you do. I feel comfortable de-escalating use of bispecifics as soon as I certainly achieve deep response. But even in those patients who achieve like VGPR or better, after 6 months or so, I feel comfortable de-escalating just at least a little bit to every other week or so to strike a balance between efficacy and safety. But certainly in patients who achieve very rapid deep response, I
Hmm.
felt comfortable de-escalating to monthly. And
Hmm.
I have select patients where we have escalated to every 2 to 3 months, and we'll soon be showcasing our experience. Sloan Kettering,
Hmm.
the 30 plus patient, I think, cohort recently, where on redosing of patients who were with prolonged break, among whom 70% CRS was noted, which is kind of study reported, when all of them were redosed without any step-up dosing, none of them had CRS, which was really impressive and helpful, I think, for community practitioners, right, beyond
Hmm.
academic sort of experience, to know that there is data that shows that it's feasible actually to
Hmm.
resume the dosing without needing to take patients again through re-step up, right?
Yeah, that's exactly. I had a patient that had a break from, and we just resumed that without that step up dosing. The other thing we have done is exactly the same. Once a response is generated, we can extend the interval. We take our cues from the folks like yourself and the main centers as far as those decision making. We follow those clues and experience.
No, for sure. And I'll certainly mention your colleagues at academic location in Rochester have contributed immense amount of data,
Hmm.
including on healthcare utilization between outpatient and inpatient, really demonstrating significant resource saving in those patients who can be feasibly treated fully outpatient.
Hmm.
So, we have actually done some of that analysis, and our data should soon be available. Really serious financial savings.
Yeah.
When possible to do it outpatient versus inpatient.
Yeah, definitely. And I think we've even, interestingly enough, we're not that far from a large center, but I think it's just there is a logistical barrier that's very significant for the patients and community practices. Despite being an hour away, many of the patients can't manage to stay for 10 days in a hotel, relocate with a caregiver
Right.
for step up dosing in a main center. So I think we've seen patients in our practice forego these type of therapies for that reason. It's all the more reason to be able to draw these patients a little bit to your community oncology practice. And with the help of all these experiences by you and experts around the country like yourselves, it's really going to be helpful for all these community oncology patients.
No, we are very hopeful. Thank you. I mean, even if you look, I mean, the labels are starting to change. I mean, the teclistamab label that just got approved actually recommends only consideration of hospitalization for the first two step-up doses. So,
Mhm.
so even that's different compared to initial label for teclistamab. My hope is also that with some of the other upcoming drugs, I might also mention etentamig. So we have showed data last year at ASCO where the one step-up dosing schedule in cycle one on day one and day four with modified dexamethasone premedication leads to really the lowest CRS reported level in the literature.
Mhm.
Relapsed refractory myeloma, the overall CRS rate was 30%, of which 26% was grade 1 and only 4% grade 2. So, I mean, this is already significantly lower. So imagine giving
Yeah.
tocilizumab prophylaxis with that agent
Yeah.
that starts already monthly from scratch. So, my hope is that agents like that are potentially up and coming, right? But then also elranatamab in different schedules, teclistamab, talquetamab already has a per label Q2 weekly schedule, which I actually preferentially use. I'm curious, how do you like to use talquetamab?
So we're kind of have stuck with our use case of teclistamab, so we haven't kind of delved into talquetamab much yet. We are intrigued by this whole idea of this trispecific as well. I know you had just mentioned about a clinical trial. I do believe there's a clinical trial coming down the line with trispecific antibody that uses prophylactic tocilizumab, and
Right.
that's directly aimed at this whole idea of getting community oncology practices using these medications. It's a great use case, I think. So be interesting to see what happens with that.
The UPTEC trial was looking at the tocilizumab prophylaxis with teclistamab, and in their report of 24 patients, only one occurrence of CRS happened. It was grade 1. And there's actually currently, we're part of that study as well, arm that's open with dexamethasone premedication only during the step-up dosing periods for a couple of days. So I am very excited to see what that does, because imagine the situation if the dexamethasone can approximate the outcomes in CRS mitigation strategies compared to tocilizumab, which is significantly more expensive, right, and more
Mhm.
challenging to keep on formulary, etc. This might really lead to serious improvements and strategies for how to mitigate this risk for broader community use.
Yep.
But we've been working very closely with developing our outpatient step-up dosing. We actually developed it on our own within the Mayo Clinic Health System without direct support from the destination practice because we thought it would be more directly applicable to community oncology practices regionally and around the country. We brought one of the PAs on from Rochester for the educational component more recently. So we're building this thing out pretty well right now. So it's pretty exciting to help. I think you hit the nail on the head. They support like thinking of the community oncology practices from the start, where oftentimes the big systems, there's a lot of disconnect between the community practice and the main center.
The reality is, vast majority of our myeloma patients are actually still centered in community.
Yeah.
Um, you know, there's distances to be considered. I've had patients that colleagues wanted to refer, and because of distance, they just decided they couldn't, and
Hmm.
therefore we had to choose other therapies that
Hmm.
potentially are less impactful and powerful. I'm looking forward to the time when overall accumulation of data in terms of CRS mitigation strategies, infection prophylaxis strategies, and feasibility of step-up dosings with different frequencies and even especially different combinations, right, can really start dramatically impacting sort of the overall outlook of this disease and even potential for curability, right?
Yep.
Because the PFS on Majestic 3, for example, is just
Hmm.
incredible, but there's infection risks associated. So you just need to strike that balance. And then all these other that we mentioned combos with cell mods, with PIs,
Hmm.
MM20, MM30 with elranatamab and others with teclistamab and such, and tantamig as well. I think they will really end up changing the way we use therapies, including in the early line and also frontline, right?
I think also what I've noticed since doing this project is that the myeloma space is the perfect use case to get this new technology out to community oncology practices because of transplant, and there has been this good communication back and forth, usually with a lot of community oncology practices and a destination practice where you have to have those patients back and forth for transplant or transplant evaluation. So that communication has been pretty historic, and it's pretty natural for a lot of places.
Yeah, I agree, definitely.
Thank you, Doctors Baljevic and Ticku, and many thanks to you, our listeners, for joining us today. As a reminder, to view the full program related to today's content and to learn more about optimizing BCMA bispecific antibody therapies in relapsed refractory multiple myeloma, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.